Thank you all for joining our Fall 2020 virtual community conference. My name is Chris. I am ICN's Engagement Campaign Director, and I will also be, I guess, your MC for the evening. I'm going to do a couple of slides to do some housekeeping things. And then I'm going to pass it over to the real stars of the show, who are all the presenters tonight. Likely we have more individual presenters than we have before. You are also part of what is likely going to be our biggest virtual community conference. We moved it to Crohn's and Colitis Awareness Week this year with the hope that more folks would show. And so we're excited that you all are here and have joined us. A couple of things. One, if you're on your phone and you have to navigate away, please don't use the hold feature. Two, if the name is inaccurate or what you typed in when you registered is wrong, if you can let us know. We want to make sure that that we capture everybody who's attending. And then if more than one person is viewing with you, if you could type the names in the chat box. Finally, this is being recorded, and we are going to share video of it on our social media channels of the presentations. So we just wanted to let everybody know that. So I'm going to have two questions to start off. First, if you could in the chat say what care center you're from, if you're associated with one. If you're not, where you maybe where you live, if you're comfortable, state, city, whatever, and your name. And then there's a second thing that I'm going to ask. We are trying to learn more about what avenues are effective at advertising or promoting events that we're having. And so I'm sharing a poll right now that asks where. How you heard about this event. I'm going to leave that poll up for the entirety of the presentation tonight. And once you fill it out, it should leave off your screen. But when new people join, they'll see the poll. And so you'll hear me mention it periodically throughout the presentation. A little bit about a virtual community conference. We see it as a way to build community in a time when folks can't get together. This is actually something that we did pre-COVID. We've been doing this since 2017 because we're a network that's spread out across the country and across the world. We want to give patients, families, and clinicians a chance to connect, celebrate successes, learn more ways to get involved, and hopefully there will be something for everyone. And you can follow us on Twitter, #ICNVCC. And there's some concrete things that we're trying to accomplish. One, increase knowledge and awareness of the ImproveCareNow community. Two, give you all an insight into more ways that you can become actively involved. And describe the different opportunities in the community. Our agenda for tonight, in just a second, I'm going to pass it off to our executive director and clinical director to give an update. And then we have a presentation on race, ethnicity, and IBD, trends in IBD research, community engagement in the time of COVID, and finally, our Patient Advisory Council and Parent Working Group are going to present about what they're doing, how you can be involved, everything that they work on, and how they make a difference. A couple other things. We are going to be switching back and forth presenters throughout the presentation, and so sometimes I'll unshare my screen and then give it to somebody else and pick it back up. Two, I will, in between presentations, you'll hear me come back on and talk about some of the things that we're doing and why they're important to the community. Also give reminders for things like the poll with how you heard about ImproveCareNow. And so, finally, we move quick. Part of the goal of this is to have shorter sessions so that we can allow more opportunities for patients, clinicians from across the country to present. That means at times there may not be time for questions during presentations, but you should use the chat box. We are going to, we think that is a good way to continue the conversation, even when, we're not doing breakouts tonight and things like that. But this is absolutely intended to be an event where that's participatory, right? Where folks have a chance to talk and share and learn. And so without further ado, I'm gonna unshare myself and I'm gonna pass it over to our first presenters. You're ready to go. And if I slow down or something, just let me know, but I think I'm good.
Okie dokie. So hi, everybody. Thanks so much for your patience. I am Kristen Howe. I'm the Executive Director of ImproveCareNow. I just wanted to thank you all for spending a little bit of time with us either tonight or this afternoon, whatever time zone you're in. I'm really delighted to have the opportunity to talk with everybody and just share a little bit about where ImproveCareNow is headed over the next couple of years here. And you can go ahead and advance. Great. So before we dive into that, I think it really makes sense for us to just ground ourselves a little in ImproveCareNow's common purpose and community values. After all, I feel like this really is why we're here tonight, spending time together. We're investing in each other and in our community. And so again, I just want to thank you for giving so much of yourselves to the work of this network and for what you do every day to improve the lives of children, not only maybe your own, but all children living with IBD. And you can go ahead and advance. So I've not had the opportunity to get to know many of you yet. I'm about 6 months into this role, and I just want to recognize that we are, I feel like, crossing into a new phase of the network. And as I look at the path before us, there's so much that's unknown about what lies around the corner and what obstacles might be in front of us. 12 months ago, I don't think anybody could have predicted that we would be about to spend the coming year managing this global pandemic and how we all have to modify our lives accordingly. And if we've learned anything during 2020, I think it's that change is really certain and inevitable. And the way that we embrace and respond to that change as a community will shape the network for years to come. Each of us really brings something unique and special to this network, and we all have a role to play in the evolution of ImproveCareNow. New leadership also, I think, inevitably brings change, and some things will look the same and some might feel different, but I want to assure everybody that we will never stop focusing on the future. We'll never stop focusing on improving outcomes for all members of our community and improving on the network itself. Advance. Just by way of giving you all a little bit better line of sight to the ImproveCareNow leadership team, I wanted to share this schematic that was also shared during the last community conference. And it indicates where we've really been focusing our efforts over the last 6 months or so. And this is just an attempt to demonstrate that while I, along with our clinical and research directors, each have our own individual scopes and roles to play, we do work together as a team to advance the work of ImproveCareNow and hopefully increase the value that we're providing to you all and to all of the members of our community. Next slide. We also know that ImproveCareNow is much more than a constellation of any individual or even leaders. It's a community that works together to make the most of what we have. We're a community committed to seeing and hearing all of our members. We're really a community of pioneers who recognize that we are stronger together and will go further together. And I don't think that statement has ever been more true as it is right now after the year that we've just had. Next slide. A pioneer is someone who steers a new course through the unknown. Being a pioneer is not easy. The work that we do is not simple, and it often takes longer than we'd like. As members of this community, we must at times rely on our own adaptive, go-for-it nature, enabling the component parts of our network to be nimble and resilient in the face of change. It's our collective willingness to commit to a challenge, to a shared purpose that simultaneously elevates us as a network and pushes us forward to build together a next generation of practices that will continue to improve the lives of patients and nudge our healthcare system as a whole towards a more equitable and humanistic approach to care. I think ImproveCareNow, oh, can you go back? Thanks. I think ImproveCareNow at its core really is a pioneering organization. And we're dedicated to navigating the uncharted in the way of advancement. I just want to take a moment to again say that I'm so excited to join this network of trailblazers and feel like you all have really made the most with what you have to manifest and manage a set of tools and practices that have dramatically improved the health and lives of patients and really changed the status quo both within and outside the healthcare setting. So I just want to recognize you all for your part in that. Next slide, please. All of this kind of brings our focus as a network to what we are thinking about for the next handful of years here. The three themes that you see in front of you, engagement, equity, and effectiveness, I think will be echoed in the content shared later this evening and in your future interactions with the network. Just a couple of moments ago, I shared the mission of ImproveCareNow, which is a commitment to improving outcomes for all children and adolescents with IBD. We really believe that this will only happen with continued engagement on the part of the community and with those around us, and with a focus on equity to ensure that when we say all children, we really mean all, regardless of their socioeconomic background, their race, or ethnicity. Next slide. So we'll start with engagement. I just mentioned that we're committed to building a stronger and more inclusive network, which enables our continued advancement together as a community. By providing all of our members with what they need when they need it, we're able to match each patient's needs to the best medical and non-medical resources in order to achieve the best possible outcomes for that patient. And by continuing to foster relationship with our funders, we ensure that ImproveCareNow stays at the forefront of innovative care delivery and continued advancement for pediatric patients with IBD. So what you see in front of you is really just an articulation of why engagement is so important and why it will continue to be a theme in the network in the coming years. Next slide. To that end, we're going to ask each of you for your continued support. If you haven't already seen this, you'll see more of it in the coming weeks and months. We're asking for your continued support of the Circle Campaign Challenge. As many of you already know, the ICN Circle is a bi-weekly email where you can read stories of how patients, parents, clinicians, and researchers are working together to improve care for kids with IBD. You can preview new IBD tools and resources and stay up to date on the latest research. We know that parents and patients also report improvement in health and mental health as a result of their access to this online community. Our goal is to touch about 12,000 people with Circle by September of 2021. Advance, and as you can see, we have a long way to go. So we will need your continued help and engagement in order to get us there. Advance. So if for some reason you are not already connected to Circle or you want to learn more, you can scan the QR code right in front of you on the screen, and that will take you to a site that will allow you to share further and learn more about the Circle campaign. Next slide. So what is the point of engagement if some members of our community are not supported? Why are we talking about equity in our network? Why now? Advance. Certainly, we were all influenced by the death of George Floyd and others who elevated the Black Lives Matter movement to the forefront of our social discord. You know, as members of a healthcare community, Advance, we also view this movement through the lens of a global pandemic that has uncovered underlying disparities in the fabric of our healthcare infrastructure and delivery system. I was personally also deeply affected by the passing of Ruth Bader Ginsburg. And I say this not at all in the political sense, but rather with a recognition of our collective loss of her very pioneering spirit. Advance. And it's through this lens of a pioneer that I view this quote: fight for the things that you care about, but do it in a way that lead others to join you. As a pioneering organization, it is the responsibility of ImproveCareNow to lead in a way that encourages others to join us in our efforts to uncover, understand, and combat equality gaps in our own community. And with that, I'm going to turn it over to Dr. Shahzad Saeed, our clinical director, to talk a little bit more about the specific efforts that we have planned to address inequity across ImproveCareNow.
Thank you, Kristen. Hello, everyone. Thank you for joining us at this evening today for not only sharing, but learning and helping us really pivot to the new objectives and what we're sort of trying to sort of close the gap in health inequities in IBD. As part of the fall community conference, we did some pre-work and reached out to centers to get a sense of what they were doing in their own environment about looking at, studying, or closing the gap of health inequities within their own center. We heard from some of the centers, and some of the centers were sharing their insights when we actually met virtually in that community conference. So what did we learn? It turns out, as part of our regional breakouts, that a lot of the centers wanted us to focus on these six points as priority focus areas: racism, access and transportation, education, health literacy, zip code, and insurance. And some of these sort of areas and focus areas percolated during that regional breakouts and involved some work that the centers were doing in their area, but also was sort of a charge for us to think about as we sort of pivot to the future and start strategic planning. This was very timely because, as most of you know, that we are working on migrating our registry to a new platform. And this focus in health inequities, these focus areas can help us really think about these new areas that we can then modify and build into the new registry, and start thinking about building measures to track and help work on. Next slide, please. So as part of this learning from the fall community conference, we were hoping for the last quarter of this calendar year, this pivotal 2020 calendar year, to share current state of the network with the community at large. And you guys, if you remember, seeing some of the gaps that we identified already in the network and in patient outcomes based on their race and ethnicities. We also wanted to generate discussion, which we did during the regional breakouts, as I shared in the last slide. And then we wanted to sort of focus on compiling a list of efforts and priority areas, as we sort of saw in the last slide. As part of our charge for this last quarter, we also proposed as network leadership to the board to establish a network-wide diversity, equity, and inclusion committee. And the board readily agreed to this proposal. So we are happy to sort of announce that we are starting to conceptualize the work of this committee. We would hope that this committee, which is very important, and will help us really think through the health inequities within the network, will be co-led by a physician, a parent, and or a patient. The charge of this committee will be to help us achieve the equity goal for the network for the strategic planning cycle, and will directly report to the board with a liaison from the board embedded in the committee. We will also, this committee will also help us, but we will also look to you as community members to assess the network's diversity gaps and look at our leadership, as well as the board of directors and staff to better reflect the community that we represent. Next slide, please. Our hope is that with the foundational work in this last quarter of 2020, we can then focus on our next handful of years, as Kristen had mentioned earlier, as what would be our strategic goals. And we would be hoping to focus on equity gaps across ICN by defining the gaps, by being aware through your center level activities, along with information and charge by the network-wide DEI committee, and then incorporate that learning into the established path to mastery model that we are already aware of, as well as know that it works. And we would work together to writing our own equity story. If you remember from the first couple of slides, when Kristen shared the mission and vision and values of ImproveCareNow, the first value actually was inclusivity of ImproveCareNow. And I think we are really honing in on that in this new strategic planning cycle. We are hoping, next slide please, that together we will learn, and by partnering with you, we will make it happen. And with that, I would end and pivot to Chris to take over, but I will have one ask off of you guys as community members. As you heard from Kristen about the Circle Challenge, I am gonna challenge you all as attendees to reach out to at least 5 family or friends to become and sign up for Circle. So this is a Ponzi scheme in a really positive way.
All right.
And Chris, with that, I hand it over to you.
Thank you. You guys will hear more about Circle throughout the presentation because I'm going to talk about it a lot. But right now I want to pass it over to our first group of presenters. I'm not going to read all their names because I want to give them the floor. This section is more a discussion with them. After this, we have trends in IBD research. After that, we have COVID or community engagement in the time of COVID. We are running about 10 minutes behind, just as a heads up. But I'm gonna hand it over to the next group. Y'all, when you all are ready to hand it back, just let me know and I'll unmute and we'll get ready to move on to the next session. Without further ado, y'all can take it away.
Thank you so much, Chris. I'm so excited to see so many people show up to learn more about IBD. It's Crohn's and Colitis Awareness Week, which is great. And as mentioned earlier, you know, the country has definitely paying more attention to experiences of minorities now more than ever. It's always been important. But it's also important that the IBD community as well takes the responsibility and time to listen to minority patients and their experiences with their care. So to highlight this, we have a panel, a wonderful panel of people who are going to share their stories and shed light on what it's like as a racial and or ethnic minority with IBD. And if there's time at the end, we'll definitely take questions from the audience. I'm going to quickly introduce the panelists. So we have Dr. Sabina Ali, Associate Clinical Professor and Director of the IBD program at UCSF Benioff Children's Hospital, Oakland. We have Christian Lawson, PAC co-chair, diagnosed at 8 years old and is a junior at Oakwood University. We have Rosa Kalikian, a PAC member pursuing master's in social work at UC Berkeley. Her IC center is UCSF Benioff. We have Tina, PAC member and Crohn's patient and optimist, pursuing master's in public health at Mount Sinai School of Medicine. And we have Noor, PAC member with a master's in global medicine from UCSD's IBD clinic. And my name is Maha. I'm a PAC member and sophomore at UC Berkeley. So the first question that I want to bring up to our panel Did you face any delays to diagnosis and microaggressions in your care? What barriers and gaps in care have you experienced? Christian, do you want to answer this question first?
Yeah, so thank you so much, and good evening, good afternoon, wherever you might be. My story, I shared my story before. I actually shared it for a community conference, and I shared how through my experience, I had to deal with almost like a delayed diagnosis where everything that the doctors were trying to do to treat me, it really wasn't working for me. It was like a roller coaster, up and down with the remission, trying to figure out what was going wrong, what we hadn't considered, or what options we should have considered. And so it was very hard to really enter spaces where I had seen a lot of colleagues and peers who um, didn't have such a severe case, but they were able to reach remission before I was. And so it kind of ruined my whole taste in regards to treating my disease, kind of ruined my mental health because I wasn't so willing to open up and speak out about my care and speak out about how I felt. So I want to mention that when you think about minority care, when you think about these inequalities in healthcare, you got to consider the fact that minority mental health is important. A lot of times, when you're treating a lot of minority patients, they've grown up in environments where a lot of the parents or a lot of the individuals in their lives have told them not to say anything, to just keep quiet or to keep silent. And a lot of times it's hard to really break down that barrier and have that open transparency communication with their care provider team. And another thing that I would suggest is um, sometimes I know a lot when I was on certain particular medications, I was told that it was working for certain individuals, and I never doubt the statistics, but I didn't know whether or not these individuals looked like me. And so it was kind of hard to really trust in something that I didn't really know a lot about, or didn't really have a lot of statistics that showed that it worked for a minority just like me, myself. And then sometimes I feel like minorities are not really looked at as individuals, or looked at as something that really how do I say this? That really deserve the care that they need, but more as a number or as a cluster. And really separating that and breaking that down and understanding exactly how minority patients are taken care of and what environments they come from will really help us bridge those gaps within inequality in healthcare.
Thank you so much. Following up on that, Tina, I'd love to hear about the biggest gaps in care and barriers to care that you've experienced as well.
Thank you so much, Maha, and thank you to ImproveCareNow for this event tonight. I wish you all a happy Crohn's and Colitis Awareness Week. As Maha just asked me, and as Christian so wonderfully elaborated on, I think it's supremely important to consider minority mental health care. I think with IBD and living with IBD, so much of it is physical, but so much of it is also mental health related. In my experience, some of the gaps in care that I've experienced have been very much cultural. I think there's been a lack of cultural awareness, which has led to a lack of like cultural sensitivity and really understanding of what my experience was as a South Asian patient living with Crohn's. So when I was first diagnosed at the age of 22, it was really hard, first of all, this was 15 years ago, and it was really hard for my doctors to even wrap around the head that someone of my background has this disease and that it's progressing as severely as it was. And I think one of the gaps that I faced intensely as my disease rapidly intensified was this sort of gap between understanding, the dietary aspects or the herbal aspects of my culture. So what happens a lot in my culture is a lot of people prefer to treat with herbals or Ayurveda, homeopathy, with dietary sort of therapies, and really look to medication as a last resort. And as we know, with proactive disease management, especially in intense cases of disease, this proved to be very deleterious to my health to go about this route. I was dropped as a patient when I was 24 years old because the doctor could not understand why I was not pursuing biologic therapy and why my family was so against it. And there's this real fear in my culture, and there was no way to bridge that gap between the doctor, my family, and me. I felt caught between my elders and my society and my culture and what my doctor was recommending, and I wasn't sure which route to go. So I felt like that was really hard for the doctor to understand where I was coming from culturally and how caught up I was. So that was one aspect of things. As my disease progressed, as I started to have surgery, I now live with a permanent ileostomy. I had a J pouch for some time because I was originally diagnosed with UC. What had happened was, I think I wasn't being taken seriously, especially when it came to pain management. And we hear this a lot from patients, but especially so of patients of color. I think automatically, whether it was in the ER, whether it was at top hospitals, Mayo Clinic, Cleveland Clinic, where they would look at me, and I've had fellows say to my face, "But Tina, you look so good." I'm like, have you looked at that stack of files that I brought from New York for you to see? And once they would do an ileoscopy or pouchoscopy, they'd be like, "Oh my God." So that's the thing about this disease. It's so misleading from the outside. And sometimes even there's this gap in medical professionals understanding how much pain we're going through. To give you an example of an extreme thing that I went through at Mayo Clinic about 5.5 years ago, I had my J pouch excised. And during this time, that surgery was messed up in New York. So it was corrected at Mayo Clinic. I had a large wound created on the side of my bottom to get to a massive abscess, a pelvic abscess that I had, and to clean all of that out. I was given very minimal pain management for this, and I was having the wound cleaned out every other day under sedation. The third time they went in to clean it out, they decided not to use sedation. They wanted to see if they could discharge me. This was something I was not able to speak up about. It was very hard for me, and I was screaming in pain. Luckily, my mom was in the room, and she had to stand up for me. She had to advocate for me and say, "You have to put her under right now." And she had to threaten a lawsuit. And it was one of those things that shouldn't have happened that way. I should have been heard. My screams should have been enough for the medical professionals, the PAs who were handling the procedure, to really hear me on that. And I really do believe that as a woman, and as a woman of color especially, I was not taken seriously. That I present a certain way to them that makes them think that, oh, she can handle this. I couldn't handle it. And I remember a month later when I was being discharged from the hospital, the PA said to me, "If you could have handled the pain better, we would have let you go sooner." And till this day, I can't wrap my head around that. I think there needs to be so much more sensitivity when it comes to understanding what patients need and how much pain this disease can cause, especially from flare-ups and after surgery. So I really think between pain management, between understanding some of these cultural aspects and gaps, that we can do a lot more to help patients of racial and ethnic backgrounds.
Thank you so much for sharing that. I quickly want to, as we bring up, barriers to care and like different barriers that minority patients face in their care, Dr. Ali actually put together a presentation that we showed the first time that we did this presentation at the LOCC, and that will be sent to everybody. So I highly recommend watching that as well. It has some really great information on the different statistics and data around minority patients with healthcare and with respect to healthcare. So my next question is to Noor. Why is it important to see meaningful representation in health advocacy spaces? What difference would this, have made for patients?
Yeah, thank you, Maha. And I shared this anecdote last time also at the conference. And I think it does a good job putting together the perspectives of minorities who share similar experiences to Christian and Tina, and how overall that affects their long-term perception of themselves, how they interact with their community and at large with their providers, and discussing their health. This particular anecdote took place when I was actually volunteering at Camp Oasis last summer, actually, 2019. It's probably a little hard to imagine pre-COVID days, but they did exist. So this was at Camp Oasis, and I got to know a really wonderful camper. She was just 14 years old. She actually was just recently diagnosed with Crohn's. So her diagnosis has been no more than a year. And she was a wonderful young lady, so wise and so intelligent. And I was just so impressed by her, did very well with her peers. And then at some point, during time at camp, I noticed that she was kind of alone and not really engaging with all of her friends and not really participating in the activities. And I just kind of wanted to check in and make sure she was okay. I wanted to make sure she didn't have to see the nurse or that she wasn't feeling well physically. And I kind of talked with her. I sat down next to her and we chatted a little bit. And I asked her, I was like, are you okay? Do you need anything? And then she reassured me that she was doing fine physically. But I noticed she kind of hesitated a little bit. And I said, are you sure? And she said, she's like, I don't feel like I belong here. And I said, well, what do you mean? All the other kids, coming to camp and coming to camp specifically for IBD patients, to them, it felt like home, being able to connect with their peers with IBD, something they probably couldn't connect with their peers at their regular school or just their normal friends. So this was an opportunity for them to just really feel at home and, for the first time, not feel very isolated with a disease that they really can't talk to about their other peers. And she said, Noor, I don't feel like I really belong here. She was like, yes, I understand that, I have IBD, but she's like, look, I'm the only Black person here. And that really touched me really hard. And I understood where she was coming from. And I felt there was nothing really that I could say at that moment that would make her feel better. There was really nothing that I could do. And I said, I was like, well, how did you learn about this camp? I kind of wanted to figure out, it was great that she was there. And I was so happy that she was there. I was like, well, how did you find about this? And she was like, incidentally, her grandmother happened to know the coordinator and they kind of connected and that she was able to kind of camp. So the whole goal with that experience and then speaking with this young lady is that I think we can do a little bit better in trying to be more inclusive. We know what's missing, and the goal ultimately is to figure out how we can put together this puzzle and including minorities more. Why is it there's only this one person in a minority who was at camp, and that she found out completely by accident. And I think if she had more peers who she could relate to also on a racial level, would definitely make a difference in her treatment and how she does overall, and being able to talk about, her disease with, a community that she can directly relate to. And I hope that we can continue to think about this and work towards that. Thank you, Maha.
Thank you, Noor. Christian, I would love to hear your thoughts as well on, representation, what it means in health advocacy spaces, and as it relates to the IBD community.
Yeah, so my perspective is that when it comes down to the treatment options that we offer for IBD care, I feel like there needs to be more statistics that are made in order to fit minority patients. In regards to whether we're putting a patient on Humira or if we're putting a patient on Remicade, I feel like that patient needs to know exactly how many other minorities have come before them and have been able to find success rates with reaching remission or being able to be stable enough where they can go to either finding another additional drug or additional medication that will help them reach remission. So I think when we look at the numbers, again, I don't really feel like we should cluster the numbers together. I feel like there should be some kind of separation where people can, especially in minorities, can understand exactly where and exactly how the treatment got to this number, because there were care providers who were willing to take the time out in order to make sure that minorities were taken care of. And a lot of times, I remember when I was growing up and when I was first diagnosed, I heard of this disease as being like a white people disease. But I never really, as a minority, thought that I could get a disease like Crohn's disease. But having those statistics would have made me and my family and so many others in my life so much comfortable knowing that this helped somebody that looked like me or that was a minority just like me.
Thank you so much for sharing that. So with the pandemic, telehealth has become increasingly common. What barriers to care has telehealth presented, especially for patients from racial and ethnic minorities? This is directed to Dr. Ali.
Thank you, Maha, for bringing an important topic. Telehealth has closed barriers, but on another side, there are still barriers to care, and we have seen that as how Kristen also presented in her initial that minority patients have been more affected with this pandemic. So definitely telehealth has provided care in these situations which we are when we have limited accesses and concerns of going to the hospitals or the ER or living far away and traveling to your home center. But we have had situations where, we all know telehealth needs an Wi-Fi access, a good connection. Patients have not been able to have something like this available readily. I have had patients who have attended their telehealth clinic from a car because that's where they get the best internet access on their phone and maybe not in their home. So, but we have had patients who have lived far and we have been able to provide care and not worry about that they won't get their medications or we are not going to be able to check in with them in this. So yes, but I would also love to hear from our panelists how telehealth, has been for them. And I mean, also that is something, we all would want to continue in the future, even post this pandemic, because it has a lot of positives.
Would it be okay if I shared a few thoughts? So just in speaking to other patients and my own experiences, given the pandemic, I think initially it started off as extreme fear. Many of us are on immunosuppressants or biologics, and many of us are afraid what that meant for COVID-19. Were we more susceptible to it? Were we, there was a lot of concerns there. And of course, as minority patients, there were even more concerns because there's already gaps in our care. would those gaps further widen? And as we've heard and seen over the last several months, that has definitely been the case. But I think where things have come together and really helped a lot of us, I know for me specifically, a lot of my appointments have been telehealth. I've still had to go for blood work, stool studies, I still go to the lab here and there. But one of the things that really suffered during this time were some of the functional GI issues that I was dealing with, going for certain wellness appointments. I go for pelvic floor physical therapy. I go for acupuncture. These are weekly things for me. So when New York City was shut down, this was a really huge problem for me. And I've heard this from other patients who are able to stay out of the hospital because they have certain wellness visits that help them maintain their care. So I have heard this as a large issue, but where do I think, this could be something that we could merge in the future? I really think telehealth is very useful. As a patient who's had several surgeries, many follow-ups, had to travel into New York City from New Jersey after surgeries, having virtual care to show, erythema nodosum to your doctor, or some, eye manifestation that you're dealing with. It's life-changing for us to not have to sit in the car, wear a diaper because we're afraid that we're going to have an accident in the car, is life-altering for us. And I think this definitely has to be considered. Of course, if we need an iron infusion, if we need a Remicade infusion, if we need B12 shots, that's different. But I really think that telehealth has changed things if we can get this appropriately covered by insurance to make sure that we can maximize our healthcare and maximize, physicians being able to use this resource. I think this could really change the way healthcare is done and really help a lot of patients who are very much struggling.
Thank you. Those are some great insights into, both the barriers and advantages. And like you said, going forward, I think this will be a really important thing that healthcare focuses on. So do we have time to take questions from the audience?
So probably not, which I don't want to say. We're running about 10 minutes behind.
Yeah.
How about can we do? I'm trying to think of. Could we do folks that have questions? Maybe type them in the chat, and you all can answer in the chat box. Does that work? I don't want to cut the presentation off.
No, of course, totally understandable. That sounds great to me. If people have further questions, I think most of us are going to stick around. So.
Becky also had a suggestion. Becky Wolf, who will be presenting later and is one of the co-chairs of the Patient Advisory Council, gave the ICN patient's email address in the chat, where y'all can email questions and maybe they can follow up. Is that okay? Sorry, I don't want to. I'm not trying to.
Yeah, sounds good.
Awesome. Thank you all so much. I am going to pass it on to the next session rather quickly, but first I want to share this. I hope y'all can see my screen. It should be a quote and then a picture. If you cannot, let me know. We talked about Circle earlier. This is I want to bring it up throughout the presentation as a reminder. We've learned some things about patients and families who are subscribed to our Circle e-newsletter. One is that they are 4 times more likely to download resources. Some of the care centers in the ICN network actually ask patients and families to sign up in clinic. We know at those centers that patients and families who are there are about 4 times more likely to access the resources that are produced by all of the folks who are presenting tonight. And so we would encourage you to do that. Without further ado, I'm going to pass it over to our next presenters and unshare my screen so they can share for updates on topics in IBD research.
Thank you, Chris. So yeah, I'm just gonna go ahead and share my screen. So can everyone see my screen? I should be on the IBD Research Trends title slide.
Yes, we can.
Okay, thank you. All right, so I think before we get started, it's probably appropriate just to introduce ourselves. So I'll go ahead and start it off. Hi, everyone. So my name is Rohit Aitha. I am currently a senior at Rutgers University, and I was diagnosed with Crohn's disease at the age of 17 in 2016.
Hi, I am Sabina Ali. I'm a pediatric gastroenterologist at UCSF Benioff Children's Hospital.
I am Seth Kahn. I was diagnosed with Crohn's when I was 12, and I'm a patient at Cincinnati Children's Hospital.
Hi, good evening. My name is Tomoyuki Mizuno, and I am a clinical pharmacologist working for Cincinnati Children's.
All right, thank you, everyone. We just wanted to quickly acknowledge that Missy also helped us contribute to the presentation today, but is unfortunately able to make it today. Basically, just to give a brief background, we wanted to try to identify some emerging research trends within either the past year or the past few years.
Thank you, Rohit. So modern goals of IBD care has now been that we would like our patients to be in deep remission, meaning that we are trying to make sure that we turn off all this inflammation and confirm it with some kind of a measure, whether this be looking at your labs, looking at mucosa itself, and also along with it, monitoring closely growth in a younger patient, maintaining this remission, and optimizing the treatment and making sure we remain less and less use of steroid and remain steroid free. Along with it, monitoring complications and monitoring early disease relapse. If we use the treatment early and optimize therapy, we can have a greater impact. But we know some patients get diagnosed later or could have been on a therapy which may have not worked, or what if the therapy what they were on was not optimized? Do we not achieve outcome in every one of our IBD patients because we are too late when the patient gets diagnosed, or changing therapy, or the therapy was not optimized early enough? Next. So in the next few slides, I will cover what is been of interest and the upcoming research, and there is a lot of work going on in what we call precision medicine, and how do we use precision medicine and how the different diagnostic kind of a friendly approach to making sure we are getting to the final precision medicine where we need to be. Next. So advancing has been happening in looking at special markers, looking at endoscopy, looking at imaging to rapidly expand the diagnosis and disease activity assessment in our IBD patients. There has been several markers that have been looked at, but what we have known is they are completely sensitive, which means it's not a good test to correctly identify who has the disease. And also having these markers positive does not exclude if someone does. So many patients have these immune reactivity towards one or more of these markers. Previously, studies have shown that having some of these markers in combination may be possibly likelihood that someone may have a complicated disease. There has been an ongoing interest to see if we can tailor treatment more effectively based on these specific markers. However, these must be confirmed with much more prospective, forward-looking studies to evaluate how combination of these markers can predict who may have a possibly complicated course. Next slide. The gene testing, so NOD2 CARD15 variants, we have known that has been associated with an early need for surgery in some patients, more complicated course or patients developing stricture. patients with these variants may possibly benefit from early preventive and early different treatment strategies. Not necessarily every patient gets these gene testing, but also to keep in mind, having a positive gene does not mean that you will have IBD or possibly have a complicated course in every setting. Next slide. Some of us respond differently than others to the same medications that we take, or we experience different side effects from drugs. The way we respond can be due to the genes we have inherited with respect to medications or our unique genetic makeup, and our individual response may mean that a drug that is effective for one of us may be less effective for another patient. And that drug that is safe for one person may be less safe for another person. So pharmacogenetics offer this unique opportunity to individualize the drug therapy for people based on their genetic makeup. Testing people prior to initiating a drug to determine their likely response to different classes of drugs is a key emerging area of testing. Such genetic information could prove useful to both your healthcare practitioner and to the patient when choosing current and future drug therapies and drug doses. We also know we do therapeutic drug monitoring, like checking Remicade levels or Humira levels. The concentration and effects of some of these drugs are monitored with blood tests, and drug dosages can be increased or decreased to maintain the level of the established range the patient treatment needs to be. And following a drug concentration is the term we use, TDM, or therapeutic drug monitoring. If changing the drug dose is not effective in treating or controlling a person's illness or IBD, and person may still have side effects, then there may be something to think about, that they may need a different medication. Next. Thiopurine is one of the older medications which still is used and maybe possibly less used now with the newer emerging biologic in the treatment of IBD. TPMT testing is used to identify patients who possibly will receive a thiopurine can have related issues. Recently, there has been another enzyme called NUDT15 was identified as a contributor to a thiopurine metabolism, because we had seen previously that even if a patient had a normal metabolism, may still develop side effects. So this was another breakthrough of identifying a specific genetic variant, the NUDT15, in a thiopurine-related problem. Next. We also commonly use anti-TNF medications, so your Remicade, your Humira, for treating not just IBD, but also other immune-mediated conditions. But we know that some of these medications can develop anti-drug antibodies. The ability to identify patients who are at increased risk to develop these anti-drug antibodies can also facilitate selection of therapy and use of preventive strategy. So this was a study done in over 1,000 patients with Crohn's disease who were treated with one of the anti-TNF medication along with a combination therapy. And they looked at the measurement of the drug antibody. And they found that patients with a certain genome-wide association, HLA-DQ A105, was independently associated with a higher risk of developed antibody formation. And this in the future can also help us identify which patients may need combination therapy and prevent antidrug antibody formation. Next. We all know fecal calprotectin and role of the blood inflammation marker CRP. So fecal calprotectin is a stool inflammation marker, and we have learned over time it has a great correlation with how someone's disease activity is endoscopically, and also looking at this marker if someone has had Crohn's disease related surgery, to reoccurrence of disease and response to treatment. Similar levels in patients who have elevated CRP can also help us identify how their disease is progressing and activity at that point. Next slide. There also, Dr. Siegel's group, one of the adult gastroenterologists, has designed this web-based tool to display how individualizing predicting outcome for IBD adult patients based on clinical, serological, and specific genetic variables. So this tool can help providers and patients personalize decision and treatment options. It is still not available to all of us, but this is something that is wonderful and in the future may help us in more personalizing therapy.
Thank you, Dr. Ali. So I'm just going to provide, I guess, a little patient perspective on genetic testing in general. I think it's also important to understand, again, that genetic testing tells a portion of the larger picture with IBD because, at least based on our understanding now, more often than not, there are both environmental and genetic factors at play. But regardless, I think when it comes to using genetic testing, the concept of genetic literacy and whether patients are able to either understand the sophistication of these tests or just understand the biology, trying to prioritize that will be very important. I also believe that there are various tests that are undergoing clinical trials or even offered as direct-to-consumer tests, such as 23andMe, and they have a IBD research study going on. I think it's really important to also prioritize or try to prioritize patient consent and privacy with regards to how exactly this information is collected, shared, and really dealt with from start to end. And then specifically within reproducibility and administration, it'll be interesting to see how what kinds of pre-test versus post-test information are shared within the clinical setting and also collected by various providers. And then most importantly, I think when it comes to the dissemination of these tests and actually using these tests, whether they're truly accessible to the public and whether we are able to reach out to socioeconomically disadvantaged IBD patients or not.
So moving on to our next topic, we touched a little bit in our previous conversation about telehealth and mobile apps. So telemedicine in IBD care is not new, but definitely it has been available more and used more during this pandemic. There is a lot of ways to use telemedicine in IBD care, is to help monitor someone's disease, manage it through telehealth visits or teleconsultations or even phone consultations. It is, as we know, it's pretty efficient and more accessible than a clinic visit. We don't have to be waiting in a waiting room, long drive times. You call your physician in the morning, they may be able to get you in the next 30 minutes in a telemedicine visit. There is a good communication and maybe even able to spend more time through a telehealth visit. It may be less personable because it's in a different setting. There are obstacles. Yes, we won't be able to do a full physical exam. And this, and as we mentioned in the last topic, is about connectivity issue that could happen during the telehealth visit. There is a lot of interest in wearables and apps in medical care and also in IBD care. As we know, global mobile health market is expected to grow annually by 33.5%. 40% have tried to share data with the medical team as part of an app. Various healthcare wearables do help doctors to know about what's happening with the patient, EKG, heart rate, oxygen saturation, your blood temperature, even sleep quality, emotions, fatigue. There is a great app or a like Apple Watch can monitor someone's glucose management and diabetes. Next. These were the two early GI apps, more for our IBD apps. It's called GI Monitor and GI Buddy that came about as an app a long time ago. Next. There has been a lot of work and studies being done as an interest with mobile apps, looking at predicting disease activity, even looking at someone's predicting flares by looking at step measurements. If you are were taking more steps a week ago and now you are walking less or taking less steps, is that a prediction of a next flare? Looking at how deep your sleep is, and also overall your physical activity. Next. So the current landscape of mobile health is symptom monitoring, medication reminders, finding an IBD provider for our young adult patients who will be transitioning and transferring care to adult care, finding IBD-friendly recipes online, and even storing your medical history.
So I'm just going to share a couple of different apps. I think it's been covered previously, but one of the most popular apps you might have seen or tools or might have heard of by now is Doxy.me as part of our how we at least do these telehealth visits most of the time. At least I personally have been using that to stay in touch with my GI or make appointments. And it is a HIPAA compliant telemedicine tool, and it's also offered as both a web-based interface and a smartphone app. And I think that's why it's likely so popular. But with regards to a few challenges that we've identified, I think like Dr. Ali had mentioned, connectivity and technical difficulties are a big one, especially during the course of the pandemic. There's also the added aspect with I guess it's not so focused on Doxy.me, but just overall the remote sort of nature of telehealth. It's the inability to conduct lab work and physical exams, as sometimes those might be more helpful. And we've also had some patients report visits being less personable and less comfortable through video calls or video chat rather than in person. And then on the other hand, with regards to more so medication-related adherence and just making sure that we kind of stay in track with medicines. I've personally been using Medisafe, and in one of the infographics that I think it was Mercy Children's Hospital put out, they've identified Medisafe as one of the more popular medication reminder apps as well. It's another HIPAA compliant tool, and what I really liked about it was that the ability to have so many ways to get notifications, whether it's SMS, email, or just right on your smartphone, whether it's iOS or Android, as a push notification. And then something, because it's a cloud-based tool, you're able to even add in your friends and family as profiles to kind of help monitor how you're doing with staying on track with your medications. However, at the same time, some challenges including like ensuring full privacy and confidentiality, because at the end of the day, it is a cloud-based database and management system. And there's also the from a patient perspective, it's really hard to put all the medication information depending on how many different medications you might be using, the frequency, and whether they're popular or not. Medisafe doesn't have all the medications added. For me, like personally, I had to add in some probiotics that I was using that weren't covered on Medisafe. And then another thing that I was able to find was that some patients complained about the lack of customizability for alerts. So like some patients thought it would be better for different kinds of medications. You had like a different reminder rather than a generic reminder. So In terms of just general overall barriers and challenges, one of the biggest things is app fatigue. I think I think this is really defined as when you you see so many apps, right? Whether it's in addition to social media, having another app for managing your health. A lot of the times, a lot of different apps can offer too many identical features, and the requirement of you constantly checking those apps and requiring constant monitoring can be a lot for patients to handle. And even sometimes patients might ignore the app due to lack of time, lack of relevance, helpfulness, or just feeling of no short-term or long-term reward. And to propose solutions, I guess, and I think we're kind of seeing this in more recent apps, are providing real-time feedback on how you might have done over the past week, or the past month, and then even passive data collection where patients don't have to input as much data as maybe done in previously released apps. And these are two sorts of maybe solutions that can help guide us. But I think Dr. Ali will present some of the more specific challenges within the clinical and patient sense.
Yeah, so definitely connectivity, not just with the app, but also with a telehealth visit between your medical team and the patient. There has been also initially concern of using a telemedicine appointment by certain providers in healthcare systems. We know pre-COVID, there was a big insurance reimbursement issue, which hopefully will not reemerge after this pandemic is gone, and we will be able to continue telehealth appointments and insurance acceptance to that. There has been concern of privacy, security, and confidentiality with a virtual visit, but I think there has been a lot of work done to help with this process, and a lot of the different platforms we all are engaged in have provided a lot of security and privacy acceptance. There is ongoing work in looking at both telehealth and mobile app data, not just in IBD, but in other medical conditions, to support this effectiveness and efficiency, to make sure this continues to be an effective way to manage and monitor illness.
So now I'm Dr. Mizuno, if you want to share your screen, I'll hand it over to you.
Oh, I don't have my slide on my laptop, so can you keep sharing your screen?
Yeah, that's fine. Okay, I'll share it back again.
Thank you.
No worries.
So thank you. So I first briefly talk about our perspectives on the pharmacokinetic modeling in IBD. So I will start with what is pharmacokinetics and why it is important for precision dosing. So pharmacokinetics is a science to understand how the body handles the drug, which includes the drug input and output process. So next please. So understanding these processes is critical to predict how much and how long the drug will remain in the body. And this information is useful for the personalized dosing. So the next slide, please. So as we discussed so far, so one size fits all approach does not always work for medications, since each patient responds to the drug differently. So next slide, please. And next one, please. Next one again, yeah. And the biggest question here is, what is the factor causing such a different response? And next slide, please. And pharmacokinetics is one of the essential factors to connect between the dose and the outcomes. So as you can see, since each patient handles the drug differently, the amount of drug in the body could be too less or too much to obtain the expected response in each patient, such variation in drug concentration often leads to the different response to the drug. So therefore, if we measure the drug concentration proactively, we can adjust the dose to avoid undesirable responses. Next slide, please. So to optimize dosing regimen based on drug levels, so we use pharmacokinetic modeling. I will demonstrate the step-by-step process using the infliximab case in this slide. Next slide, please. So before starting the treatment, a population model can predict the most likely drug concentration profile based on the population average. And this step also takes into account the actual patient information, such as weight and predictive biomarkers. And the next step is the drug concentration measurement, and drug level results inform us how this patient handled the drug differently compared to the population average patient. Next slide, please. Next, yeah. And actually the concentration results let us update the model customized for the particular patient. And once we obtain the updated model, so we can use it to develop the new dosing regimen to target an adequate drug concentration level. As shown here, if the drug concentration results was below the target, which is indicated by the dashed line, the option would be to increase the dose amount, which is the next slide. Yeah, so we can, what I wanted to show is we can optimize the drug either to increase the amount of dose in each infusion, or we can shorten the dosing interval to get more frequent dose. So the pharmacokinetic model can help to provide a flexible combination of dose amount and interval to target the desired drug exposure. Next slide, please. Next slide. So such dose optimization could be important for the infliximab treatment, as its blood concentrations are often lower than the needed for the optimal clinical response. So this graph shows the concentration measurements in different patients observed in clinical trial. And as you can see, there is a large variability in pre-infusion drug concentration. Next slide, please. And actually, the many of concentrations were below the target concentration. So this suggests that there is still room for improvement in dosing for these patients by monitoring the drug level. Next slide, please. Next slide, please. So indeed, clinical studies indicated that pharmacokinetic guided dosing is associated with better outcomes of infliximab therapy. For instance, this result shows that drug monitoring and dose optimization resulted in the greater probability of remaining on infliximab. So this suggests that pharmacokinetics is one of the important considerations for optimal treatment. So with that, I will stop here and pass the baton to Seth. We'll talk about patient's perspective.
Hi. So when I was 12, I was diagnosed with Crohn's disease, and I started infliximab infusions every 8 weeks. However, my drug levels were consistently low as they increased the dose, and I couldn't get into remission. My parents knew a clinical pharmacologist from Cincinnati Children's, and they asked if his division could help my dosing using a pharmacologic approach. Several clinical pharmacologists from that division, including Dr. Mizuno, who just spoke, used Bayesian modeling with a software called MW-Pharm to predict my needed dose and infusion interval to raise my trough levels enough to get me into remission. Next. They published my case study, my data as a case study in a paper, Learning Health Systems as Facilitators of Precision Medicine. This is a depiction of their model's prediction of several possible dosing regimens. The green line is the predicted drug levels over time before the consult, which take into account various factors affecting levels, such as height, weight, serum albumin, and sedimentation rate, as well as my previously measured levels, which are marked by the open circles. The light blue, dark blue, and red lines represent predictions of future drug levels using Bayesian modeling if my dose was 300 milligrams, 500 milligrams, or 800 milligrams, respectively, every 8 weeks. The dotted line represents average recommended trough levels for infliximab in IBD. Next slide. They ended up recommending a dose of 500 milligrams every 6 weeks to my physician, and here's the model representing that with a few more data points plugged in after this switch and the updated prediction shown in orange. However, not all patients need the same level of infliximab to achieve remission, and with the typical recommended trough levels, I improved, but not enough. After the time period shown in this graph, they increased my dose again to create the higher trough levels I needed, and I quickly entered remission. Next slide. Pharmacokinetics and pharmacodynamics are used for many other drugs outside of infliximab, which is the drug I'm on, both for other common IBD drugs, although the evidence is strongest for anti-TNF drugs like infliximab, and non-IBD drugs, with one example being post-transplant immunosuppressants. Every patient is different. There's no perfect dose that works for everyone. So although people, including me, might wonder if a dose is too high or trough levels are too high, again, everyone is different and everyone needs different dosing and different trough levels. And that comes from differences, as Dr. Mizuno mentioned, in both how your body eliminates the drugs over time, or pharmacokinetics, and how high your levels have to be to enter sustained remission, which is different person to person, which is pharmacodynamics. And therapeutic drug monitoring and pharmacology can improve outcomes by accounting for these factors. Thank you.
Thank you, Seth. So this leads us to what our future IBD management will hopefully look like. So right now, in the gray boxes, this is how it's happening. Your patient gets diagnosed, we assess disease activity, predict a disease course by your lab values, mucosal activity. We have some information or based on presentation and labs and possibly family history and how the disease is, if somebody is high risk or low risk, and then depending on that, selection of therapy happens. In the future, the treat to target and tight control is the goal, and we are looking for more and more better predictive tools, markers, biomarkers that can help predict response, which biologic to use for which patient, who needs early higher dose, who needs possibly even early surgery, and that's what the future of IBD will look like.
So to really sum things up with regards to just emerging technologies within the IBD research community, I think there are some suggested directions. I think as we try to make advances in precision medicine, trying to identify preclinical disease, or when the disease is biologically measurable or present, but not symptomatically visible yet, it will be one of many important areas to target. Other important areas include trying to identify high-risk patients and just understanding, like Seth and Dr. Mizuno and Dr. Ali really did a great job of outlining, in that care and management can really be stratified depending on things like disease severity or optimal dosage with regards to biologics. I think with all this in mind, there's also the added aspect of trying to bring awareness of these technologies and a lot of the science at an understandable level to different subgroups within the ICN, in addition to providers such as PAC and the parent working group. And lastly, trying to engage in maybe clinical trials with these emerging technologies, and just maybe advances, not only just advances in genetic testing, mobile health, and pharmacokinetics, but maybe other emerging technologies such as artificial intelligence might really help try to improve IBD care overall. So with that, I'm not sure, Chris, if we have enough time for Q&A, but we could just take questions in the chat if you would like.
Yeah, so I think there were 2 questions in the chat earlier. Maybe if you all would like to answer those quickly, and then we can do the same thing that we did with the previous presentation. If folks put questions in the chat, you all could answer them as we move on, and we'll download the chat and get it out to the presenters later this week or early next week. Does that sound good?
It sounds good, yeah. So I think the first question we had was from Lisa. She asked on if precision medicine is being used in a systematic and consistent way across any ICN centers, or is there yet a good precision medicine model in general that has been developed yet? Dr. Mizuno or Dr. Ali, this might be a question if you know about this.
So the only one that I talked about was the prospectus and adult IBD tool measurement. I think that's probably the closest right now to precision modeling. Looking at patient characteristics, looking at blood test markers and genetic profile and predicting the course. That probably is, but I think working on that and hopefully that can lead to more pediatric work in the future.
And in terms of pharmacokinetic modeling, we don't have yet the universal model for it can be used for each hospital, but we are now in Cincinnati Children's, we are developing the user-friendly dashboard by the research group led by Dr. Phil Miner, and that is designed to be integrated in the medical health record. So once those are disseminated to the hospital, I think the pharmacokinetic modeling can be used widely by the clinical practice.
Sounds good. And then the second question that we had, I think, was directed towards Dr. Ali. Is there a genetic testing? This is from Elizabeth. Is there a genetic testing panel for IBD patients that will help our doctors manage treatment plans?
Yeah, it's a great question. Unfortunately, there is not a single a test that can, based on a genetic profile. We do consider genetic testing in complicated patient courses. If a patient has a complicated disease course, that is something to definitely think about, is doing genetic testing or whole exome sequencing, and to look at if there is something different about their disease course, but not like something that we do for every single patient.
All right, I think that's all we had to present, but if anyone has any more questions, feel free to use the chat box. Thank you.
Wonderful. Thank you all so much. That was a wonderful presentation. But without further ado, I want to hand it over to the folks from Stanford. I want to say, I watched this presentation during the community conference in September, and it was one of my favorites. I liked it so much, I feel like I practically begged them to present here today. And so they've done a great job of keeping folks connected during COVID. And I want to hand it over to them for the next presentation. If you just give me a heads up when you want me to advance the slides, and we'll move on.
Will do. Thank you, Chris. And hi, everybody. My name is Inbal Cavaler. I am a parent. And my son has Crohn's disease, and I am one of the participants at the FAC, the Family Advisory Council with Lucille Packard. And I am working here with Venus Kalami, who is one of our nutritionists, and she will be presenting with me. So Venus, how about you introduce yourself?
Sure thing. Thank you, Imbo, and thank you, Chris, for the warm welcome. As Imbo mentioned, my name is Vanus Kalami. I'm the IBD dietitian and nutritionist here at the IBD Center at Stanford Children's. And it is a pleasure to be here with you guys today to talk about community engagement.
Yeah, Chris, go ahead. Several clicks, I guess. Okay, so we'll start about what happened a year ago, let's say. So up until January of 2020, we used to meet parents and staff and come and plan our year and see what are we going to do, what activities we want to do with our community. And we used to have a yearly theme. So in 2018, for example, we worked about nutrition. We issued a cookbook. We had some cook challenges and activities that we did with the community. In 2018, we took on mindfulness and we did some activities about that. And we actually thought of taking mindfulness into 2020. And then if you think about 10 months ago, which today it looks so far away with where we're at, but 10 months ago, COVID entered our life and there were lots of unknowns. We heard about this thing that is coming from China and maybe borders are closing, maybe not. We did not know what to do. How does it impact those patients that are immunosuppressant? There was lots of misinformation going on. There was lots of fear, which resulted in stress. And on top of that, there were issues that the hospital, Stanford, has both the adults hospital, the children's hospital, and has the university itself. And they were holding town halls every week, educating their staff because there was so much unknown. And when we met at our FAC meeting, I brought up the idea that maybe we should take this breakdown as an opportunity, and we can use the same method of town hall to actually reach out to our community and educate them. So next, please. So we met and we came up with a platform that enabled us to reach out to the community and have them submit their questions. And we thought about what is interesting at each and every time slot that we wanted to address. So in March time, it took us about 10 days from inception of the idea to actually kicking it off. We were talking about what is COVID, and we invited over infectious disease representative to come and to talk to the community. We also wanted to make sure that there is medication adherence, that people don't stop taking medication on their own because they're so afraid of this unknown virus that is coming. And then in May, we were thinking about next step is things is opening. Shelter in place was about to wrap up in the Bay Area. We're looking into opening. How are we going to do in the summer? Maybe I'd like to go to summer camp. What activities are safe to do and not safe to do? And in August, the topic was about talking on going back to school. So what do we need to do if school is open, if school is closed? We main focus was on actually students that are living home and traveling to their colleges. What are they going to do? How are they going to keep their information going? And again, we invited for that one also the infectious disease doctors, and they talked a little bit about the various vaccines that are coming. Next. So we had 7 to 10 panelists all the time. It was the staff addressing various aspects of psychological, the doctors, the dietitian, the infectious disease. We had in the first one very large number of participants, and we collected again questions before and during the session. What we also did is we recorded it and we put it on the hospital website, and we saw that there was a lot of interest with the community, because if in the beginning everyone was really at home with a panic status, later on in May and August, people got back to work or needed to take care of their children. So by actually posting it online, it helped the community to watch it on their own time and see if they have any other further information they wanted to ask, and we allowed them to reach back to us and let us know if there are any questions that they wanted to do. Next one. The community was very, very pleased with this, and we got lots of responses during the events and after by reaching out and thanking us about the opportunity, about helping them to calm down, helping them to relax, to understand what's going on, to address questions that they're having. And we ask them to come up with ideas of what do they want to talk in the next town hall, how do they want us to interact with them, what will help them to help maintain and bring the mindfulness that we talked about as a theme for the year into their households. And with that, we did several things that address these topics, and Venus will address those. So next.
Fantastic. So our Holistic Healing Mindfulness series was one of the many things that our FAC inspired us to take on during the summer in the midst of the COVID-19 pandemic. And it was one of our many virtual outreach events, as you'll see. And this Holistic Healing series was born out of our previous work, where we would host quarterly holistic healing events that took place in person, where we collectively engaged in yoga, meditation, cooking, and so much more together. When the COVID-19 pandemic hit, of course, we had to put our in-person events on hold. And again, per the request of our FAC, we launched this 3-part summer series on mindfulness. And you may ask why we chose mindfulness, a second year in a row. And this was largely due to the abundance of anxiety and uncertainty that accompanied and continues to accompany the COVID-19 pandemic. So in a true holistic healing fashion, we focused on engaging in mindfulness in every sense of the term to launch this virtual series where we performed mindful movement and yoga, cooking and eating, and my personal favorite, mindful gardening. And yes, we garden together virtually. It can absolutely be done. Next slide, please. So as I mentioned, we focused this series on mindfulness to also provide a dedicated space for those who are seeking community support, seeking reassurance, to come together and feel grounded in various mindfulness activities. We really aim to kind of reframe and refocus our attendees to rethink about what mindfulness means, and that it's not really just sitting and meditating for 2 hours a day, but it can easily include the routines of daily life. So maybe that's stretching your calves as you brush your teeth, or maybe it's feeling and noting the different textures of vegetables as you chop through them, or getting dirt underneath your nails as you garden. So for our first event in June, we had an amazing yoga teacher who also happens to be a registered nurse at our organization. And during the event, we performed icebreakers, mindful breathing, as well as movement in yoga, all online in a totally collective way. So we had providers, patients, parents, you name it. We were all on our yoga mats doing downward dogs together. After the event, we set up time for our parents to gather on Zoom without the providers to have a family-friendly happy hour. Then for the second event in July, we focused on mindful eating. So we really want to tune in to our senses, the taste of a puckeringly tart lemon, the smell of the refreshing zest, the feeling of the juice on our fingers, and of course, the delicious dip that we all made together virtually in our kitchens. We got into the kitchen and together we built a yogurt ranch dip to eat with some vegetables. And we tuned into our senses in a really iterative process. We layered flavors one by one into the yogurt sauce and noted how each additional ingredient transformed that dip. And again, at the end of this event, similarly, we had another family-friendly, provider-free happy hour for our parents. Then for the last event of the summer series, we gathered once more on Zoom to mindfully garden together in early September. For this particular event, we had a significantly smaller group, and we attribute this mainly to the timing of Labor Day weekend and school starting up again. But as a result, we had a smaller, more intimate group, and we had a lot more meaningful group discussions and storytelling. So it was a really fantastic gathering. And the mindfulness aspect here rang particularly true as we were doing the meditative practice of gardening, and we collectively repurposed food scraps that we might normally throw away. Next slide, please. Fantastic. So the proof is in the numbers. Just a small note that this data reflects families who attended. And just a note, I can actually see your screen, the ImproveCareNow loop site. Thank you. Back to the numbers. So in terms of individual attendees, these numbers could be double or tripled because they reflected families, parents, kids who all attended the event. And we had pretty excellent registration and attendance for the first two events. Again, because of the timing of the last event, the third event, we had less attendance, but again, that lent to certain benefits in other ways. Regardless, across the board, you can see we had excellent enjoyment and notable increases in mindfulness knowledge for our first two events. Next slide, please. So what are our big takeaways? What does our future look like in terms of holistic healing events? From our surveys, we learned that 1-hour events in the evenings were best received, and going forward, we're hoping to engage in these events on a more quarterly basis rather than monthly. We found that the events, when they were short and sweet enough and also interactive enough, that really promoted engagement. Our surveys also showed that families would love more nutrition and yoga focused events, which we're thrilled to take on in the future. And lastly, I would say this was a powerful lesson in the therapeutic impact of togetherness, even virtually. And I think that resonates now as we're here together on a virtual conference, right? So for our mindfulness group, this was about virtual togetherness to center ourselves, to get grounded and get connected. I also want to share an anecdote from one of our attendees at our gardening event. And I just thought it embodied mindfulness perfectly. He said that he had a lemon tree that for many years would not produce any sort of lemon tree, but he decided to trim back some of the extra branches, some of the extra leaves. And then with the next summer, actually the next winter, he had a tree that was just totally saturated with lemons. And for me, I think that embodies mindfulness right there. It's simplifying and focusing, trimming away the extra leaves and branches, and grounding yourself in the meditative qualities of your day-to-day practices where you can ultimately thrive. And then on a side note, we have a sample agenda on the screen. So for anyone who's interested in a similar type of event, you can certainly check that out. And of course, reach out to myself or Inbal if you have any questions or would like to talk about this more. Next slide. So our next topic is regarding the application of telemedicine and IBD psychology groups. Next. Our fantastic IBD psychologist, Dr. Anna Varen, has trialed groups in various formats over the last few years. The groups have varied by age, frequency, the focus of the groups, whether that's coping skills, support groups, or a hybrid of the two. And then lastly, it has varied with different deliveries, whether that's in-person groups or virtual. Next. And as you can see here in this slide, in the year 2019 to 2020, groups took place only in person, and average attendance per each group was around 5 participants. Then in 2020, in spring, in setting of the COVID-19 pandemic, the groups were swiftly adjusted to a virtual format, and attendance was slightly increased to 6 participants per group. Now, what is absolutely remarkable is that in the fall group series, attendance in each group more than doubled when you compare it to spring attendance. And we suspect this was due to increased accessibility, increased interest, and more likely than not, the need for social engagement given the limitations of this pandemic on social interactions and seeing friends. Next slide. Feedback regarding groups has been unanimously positive. Some patients have shared how they love meeting with other kids with IBD, how the connections have made them happier, and that they were overall so grateful for having groups. It is and was also an opportunity for parents to connect with other IBD parents. Next slide. And of course, it wouldn't be ICN if we weren't looking to improve the process of our groups. So the future of our groups for IBD involve including co-occurring parent groups, weekly focused coping skills groups, and quarterly or semi-annual events for our younger elementary school age patient population. And with that, I will pass the mic back to Inbal to cover the future of our IBD team and to conclude our session. Thank you everyone for your time.
Thank you, Venus. It's always fun to listen to you speak. So, so what are we going to do going forward? Next week, we're going to meet with a team actually, and we're talking about our next virtual town hall. And I think on my mind, at least, it's vaccination. What can we get? Which one? What's the process? How it's being done, etc. We're going to continue discuss about the IBD support group and maybe as we go into reopening, can we keep it virtual? I suspect that part of the reason that we have double of interest and participation is not just the need for companionship. It's also you don't have to drive for 1 hour to the hospital to meet for 2 hours and then drive back. So instead of a 4-hour session, it becomes 2 hours at home. And this is something that is much more valuable for everyone. So how can we leverage that? And third is what kind of additional community events can we do in the terms of mindfulness or other scopes that we want to bring into 2021. And we have several ideas and thoughts, and really looking forward into see how can we kick and launch these activities. We're also going to talk about several SCD virtual support group or studies that are being happened with appliances that you can carry, or with the 3D virtual reality headsets that people are having. So we're just looking into improving general nutrition classes and just growing our community and the engagement and having more collaboration with parents and patients. And with that, Chris, thank you, everyone.
So first, thank you very much. Second, I wanna apologize for for navigating away during the session. I'm actually going to navigate away again to share what I was looking for. Their team, the Stanford team, put together a post on our Loop blog about this, right? And I wanted to share it in the chat box that includes their virtual planning checklist. And so it's in the chat right now. Mary Havens saved me by posting it. And so I want to apologize for navigating away, but that's what I was looking for. The other thing I want to share before we go to Becky and the Patient Advisory Council, I am going to put in the chat our post-event survey. I know we're running a couple minutes behind. That may mean some folks may need to jump early. We at ImproveCareNow, our mission is to continually learn and improve. And this is how we did it. And some of the things that are going on at the VCC tonight, this used to be 4 hours long. For example, it's only 2 hours now. Shorter sessions, things like that, are because of feedback that we got. And so I'm going to put it in the chat. If you all can, please fill it out. Sometime tonight, we'll also send it in a follow-up email with our follow-up email. Without further ado, though, I want to hand the screen over to Becky with the Patient Advisory Council. Becky, are you ready, unmuted, ready to go?
Yes. Let me share my screen.
Okay.
All right, awesome. Hi, everyone. My name is Becky Wolf. I'm one of the co-chairs from the Patient Advisory Council. So today I'm just going to talk about what the PAC is and what we're doing and where we're going. So to start off, what is the Patient Advisory Council? We're a group of patients with IBD ages 14 and up with recent or current pediatric IBD experience. We have around 70, 80 members, which is a really exciting number. And we're kind of partially a support group and partially a patient advocacy organization. So we kind of support each other and other patients outside of the PAC, as well as do advocacy work inside and outside of ICN. So we have three main pillars of things we do. First, we have communications. We're present on social media, Instagram, Twitter, Facebook, Snapchat, and we also post on the Loop. We've got a lot of really inspirational patient blogs on the Loop. So if you're ever interested in checking that out, there's a lot of good information there. We also work on advocacy. This roots a lot in toolkits, which are online resources that we create and share with patients and their families. And we also do engagement work and try to get patients more involved in different levels of care. We also do recruitment. We like to onboard patients into the Patient Advisory Council so we can represent the patient voice. So I just wanted to briefly share our leadership team. We've had a lot of leadership transitions over the past 6 months or so. So I just wanted to update everyone on this. You can take a moment and familiarize yourself with some of the names. You might recognize some of them might be new, but I just wanted to give a moment for everyone to just refamiliarize. So going over what we have done, we all know that this year has been really crazy and very frustrating and disappointing, but there's also been a lot of really amazing things that have come from it. The PAC has seen a lot of growth, and I've been so impressed and so amazed to see how much progress we've made. During 2020, our membership has increased by 18 new patients. For context, when the PAC first formed, we had around 10 or 11 patients. So during the span of 1 year, our membership has increased like 1.5 times what the original size was. So that's absolutely amazing. We've had 5 patients get involved with learning labs on different levels of leadership and involvement, which has been so exciting. We've seen a lot about how helpful that has been. We've had 2 members on the COVID response learning lab. We've had 2 patients work on the executive leadership search team. We've done a lot of presentations and Ignite talks at community conferences. And I want to thank the PAC members who have presented this evening. Thank you guys so much for sharing your stories and talking about such important topics. We've also published 19 patient-written loop posts, so please check those out. We've got a lot of material there. And we've had 5 leadership transitions this year. So over the history of the PAC, we've created 12 different toolkits. And again, these are online resources, often in a PowerPoint or PDF form that you can share with your patients and families. They're on a variety of different topics about patient experiences. They're specifically not patient advice. We're not advising people on any sort of medical discourse, but just sharing our experiences and tips or tricks we might have from living with IBD. These have been on topics such as ostomies, nutrition, disordered eating, accommodations, travel, college, a lot of different really helpful topics. I've used them. I've been involved with ICN for, oh gosh, like 4.5 years. It's been a while, and I've been diagnosed for over a decade, and I still use those toolkits. When I applied to college, I used them. When I was looking for accommodations, I use them as a template for my emails. They're very, very helpful. We've also got 2 toolkits in production right now. So I'm going to go turn it over to the leads of those toolkits to talk to us a little bit about what's happening there.
So hi everyone. My name is Rohit Daiva. I hope to present with the Research and Trends presentation already, but I just wanted to talk a little bit about our lifestyle and IBD toolkit. So I, along with Becky, are co-leading the creation of an informational toolkit in the form of a website. We are trying to document perspectives from pediatric patients, providers, and caregivers on how to manage lifestyle and with IBD. And we had a few of these, we had these following topics in mind, and we're kind of structuring them as our sections, and they are socializing, diet, mental health, treatment and surgery, and management through medication-related adherence and apps. Currently, we are in the stage of continuing to create content. For example, over the past month, we've reached out to various providers over email, or actually interviewing them over Zoom calls to cover how food insecurity is related to the management of IBD. So essentially, we hope to share some new pediatric IBD patient-related perspectives and just new information on how each of our journeys with IBD can be unique. Thank you, Becky.
Hey everyone, my name is Quint, and I'm working on this with Rishi Mehta. We're working on this together, and our toolkit, super generally, it's called the Health Literacy Toolkit. And one thing we want to I want to quickly define is health literacy. So health literacy is the ability to obtain, process, and understand basic medical information, which is obviously super important for us as IBD patients to be able to well, our goal is to identify these comprehension gaps and then to increase the comprehension of medical, health language, and healthcare-related IBD, healthcare-related events with IBD. So obviously, these are all incredibly important topics to us, and we have these really quick. Excuse me, sorry. We have these very quick 6 topics, and they are IBD 101, general overview of IBD, medications, interpreting test results, insurance, how to get in touch with your doctor, and transitioning care. And actually transitioning care is going to be working off of a toolkit that we've already created. So that's really awesome. So we can collaborate with other toolkits that already exist. And yeah, that's the general overview.
Thank you guys so much. Yeah, so as Quint and Rohit were sharing, those 2 toolkits are in production right now. So if anyone listening is interested in getting involved, please reach out to us. We are always looking to collaborate. And again, those toolkits can be found on the ICN website. I believe the link is in the chat. So now on to where we are going. We have a lot of really exciting PAC projects and developments that we're looking forward to over the next year. We're going to continue with leadership transitions and getting more PAC members involved within ICN and within the PAC. We're going to be continuing to present at community conferences, so please stay tuned for that. And we're also really excited to be involving more patients within ImproveCareNow projects and learning labs. We've learned a lot recently about how helpful that can be to have that patient perspective. If our whole mission is improving quality of life for IBD patients, the first thing we can talk about is, well, what does that look like? Because it is different for every patient. So having that perspective in projects on the ICN level as well as in care centers can be really, really valuable. We're also looking to increase membership, and we want to do this in number, but also in representation, because we recognize that if our goal is to advocate for patients, we want to be doing that for all patients. We're looking towards converting our current toolkits into a more interactive format. So we'll keep everyone updated on that, but we're really hoping to get that going. Another project that we're going to start next year is the PAC Diversity, Equity, and Inclusion Project. So we're hoping to work with the network and with the network-wide Diversity, Equity, and Inclusion Project on this. We want to specifically focus on patient experiences and from the PAC perspective here, but we have acknowledged and recognized that as a healthcare group, we have not only the opportunity, but the responsibility to start and, well, do more work to address the health gap. We're also excited to announce that we are going to be releasing a PAC podcast, which is called Impact. We're going to be doing episodes bi-weekly, talking about different topics related to IBD and being patient advocates. It's going to be run by PAC members, but we're also going to be including guest speakers. So if you're interested in getting involved, stay tuned or reach out to us. We're really excited to release that. And then again, we do have those 2 toolkits in production. So how do you engage patients? If you're a patient listening and want to get involved, you can sign up on the website. If you're a parent listening and either want to get your child involved, you can divert them to the website here, or you can also suggest they follow us on social media. You can also use our resources online. Our toolkits are at improvecarenow.org/tools. You can advocate for your patients to get involved at your care center. That can be really helpful and really valuable, as well as getting patients involved at that level, or parents involved at that level as well. You can also sign up for the circle. So I know we've talked about this a lot tonight, but I just wanted to reiterate this from the patient perspective. All of our PAC toolkits are shared via the circle. So they're all on there in a very easy to access format. And this can really allow patients and family members to access these resources that have been so valuable. So our ask for you is sharing about the circle and how staying connected has impacted your journey with IBD, and encouraging other people to check out the circle. Thank you.
Thank you so much. That was amazing. And I should say from, and I'm vamping a little bit while I'm resharing my screen. As somebody, my younger brother has UC and grew up in a time like before ICN and before the PAC. I absolutely believe that he would have he would not have gone through some of the struggles that he did if he was able to connect with other patients, and my mom would have been able to better support him if she was able to connect with more parents, which is actually where we're going next. And so I want to pass it over to Jill. Jill, are you there? Jill's amazing. She's in Massachusetts. She's going to talk about the Parent Working Group.
Okay, well, good evening, everyone. I have the unenviable position of coming after the PAC. So wanted to thank Becky and the PAC for just an extraordinary program, but also just all the tireless work you do. The PAC always represents in such a brilliant way. And we're so proud to be able to work side by side with you. So truly hats off to you and to all the presenters this evening. You've done an extraordinary job. And so I will try to wrap it up as briefly as I can. Chris, if you could please advance the slide. Okay, we can go ahead. Wanted to welcome you. We can move ahead. So just wanted to tell briefly who we are. You can go one ahead. There we go. So who are we? So we are caregivers, and we come in all different shapes and sizes and colors. The caregivers, the thing that's most important about those is that we're the ones who are trying to support our patients in the best way we can. And our lived experience is unique, and we certainly recognize that within the ICN community, that voice is valued. And so we invite all parents and caregivers in whatever shape or form that may be. It could be a grandparent, aunt, uncle, guardian. Your voice matters, your experience matters. And so that's what makes up the Parent Working Group. Next slide, please. And here's an example of just some of the gatherings we've had in some of our representation. And we can forward. So we're trying to build a solid foundation. Next slide, please. One of the unique things about the Parent Working Group is that typically every 2 years we change leadership. There has been a little bit of a desert with parents being able to go to the community conferences. And so as a result, what we've discovered is that it's been challenging to recruit new parent leaders into the Parent Working Group. So we created a key driver diagram just to really think about how do we want to sustain this organization so that as we transition leadership, we don't have to reinvent the wheel every time, kind of like our Jenga game. Next slide, please. And so our current goals are really around creating that solid infrastructure. So it enables us to move on to more significant programs moving forward. So we wanted to make sure we had a clear mission and vision and charter. We want to improve communication both internally and externally. We want to diversify parent representation on ICN committees. We want to have clear roles and reporting structure. We need to membership growth and recruitment and onboarding, and just really looking at our organizational structure and branding to ensure that it's representing all the diversity within the ICN network. Next slide, please. Next slide. Okay, so during this period of transition, the Parent Working Group is working on our mission and our vision statement just to better define what our goals and our work is. And we find that this is it's a foundational piece of our group. And so we really want to be very mindful about what it is we want to accomplish. And so during this time, this is going to be an important aspect of our work. Next slide. And the other thing is that we want to know where our caregivers fit into the QI work. And so we're looking at subject matter experts, knowledge about how we can use improvement science to affect change both within our Parent Working Group, but then also leverage that throughout the network through our local center work. Next slide. Okay. So when it comes to caring for children with IBD, the caregivers are the subject matter experts. And so we've used this kind of graphic before, but there's 8,784 hours per year that you spend with your child in being immersed in caring for a child with IBD. That makes you a subject matter expert. And so that lived experience, again, is so valuable when it comes to quality improvement and improving care for those kids. Next slide. So when we think about a work in the parent working group, I mean, if you're looking for somebody to volunteer, ask a busy person, right? But we're aware that there's different levels of engagement. And so Chris Keck is really the master when it comes to this. But we're really trying to, invite parents and caregivers to be come onto this ladder. So, we work on awareness through our monthly all calls, and it's an opportunity to people to engage in more of a laid back way if they want. We also have our newsletters where parents and caregivers are invited to contribute to the newsletter. Then there's active participation and commitment and leadership. And so, there's all different rungs where people can get involved, and we invite you to do so, because really that's the lifeblood of this organization, is making sure that all stakeholders are represented equally. Next slide. So some of our challenges, and again, I don't want to get into this too much, but there used to be funding for parents to attend the national conferences. Thankfully, when we do start meeting again, thanks to the Dr. Coletti Fund, there will be some more funding just to allow parents to engage on the national level. And again, all of this sort of relates to where the parent working group is now. With less parents and caregivers going to those national conferences, there were less opportunities for folks to engage. And so we're really trying to reinvigorate the parent working group. Next slide. And the other thing we're looking at is just our structure. How do we leverage our leadership, and how do we distribute the work so that it's a little bit more equal? Because oftentimes parents are working full-time or working, both in and outside the home. They're working at their local centers, and then to take on a national leadership responsibility is a fairly big ask. And so we're really mindful of that, and we want to make sure that we're distributing the work a little bit more equitably. Next slide. So we have some work to do. We need to improve our communication both internally and externally. We want to diversify parent representation on all of our ICN committees, and we want to grow our membership and recruitment and onboarding. Next slide. So our future, we're looking to rebrand the parent working group to be inclusive of all caregivers. We want to solidify our foundation to ensure sustainability and smooth leadership transition. We want to create a document repository. We want to base our work on QI methodology. And we really, most importantly, want to increase our local center engagement, because that's really the lifeblood of the parent working group. Where the change happens is locally. And so, part of our mission is to be able to engage with local community centers so that they're able to partner with parents and caregivers in meaningful ways. Next slide. So we have many leadership opportunities within the parent working group. Within the next 6 to 12 months, many of us will be transitioning out of leadership positions. And so we're looking to the future to have new folks join with us. Next slide. So the top 10 reasons why we want you to be involved with the parent working group.
Okay, hi there. How are you all doing today?
Okay, your lived experience will help improve the care of others. Oh, somebody's in there. You'll meet others who understand the worry of caring for a child with a chronic disease. One word, patio. And if anybody's ever been to a community conference before, you'll know the patio is a great opportunity. We did it virtually as well with Dr. Saeed and some others. It's a great place to just mix and meet other folks. We know you don't have time, but let's be real. If you want something done, you ask a busy person. You'll be a member of a dedicated, smart, innovative, passionate group of caregivers committed to improving care for all children and adolescents. You'll build incredible friendships and be among those who share your passion for improving care. You'll expand your network and be inspired by those you meet. You'll collaborate with a multidisciplinary team and learn new skills and be challenged to think bigger. And you'll be part of a collaborative think tank of innovators and improvers. And most importantly, it's because your voice matters and because we need you. Next slide, please. So not sure where to start. Well, no worries, because we all teach, we all learn here in ICN. We have a variety of Q&I webinars. We have ICN boot camps, the Circle, as we've talked about many times tonight, the Loop, parent working group all calls, and mentorship. We're here to help, we're here to learn, we're here to improve each other. Next slide, please. And remember, it just starts with one, working together with others to improve care. And I always love this quote. It says, I said, somebody should do something about that. And then I realized I am somebody. It takes just one. So have that one conversation, have that one event that you try, have that one all call that you jump on, or maybe write that one story, and you'll find that your voice really is so powerful and meaningful, and that we can't do this work without you. Next slide. And thank you all very, very much. Thank you to the other presenters and to Chris and Sydney and Dr. Saeed and Kristen and all for all your tireless efforts. This is a really wonderful and unique community, and we're accomplishing really amazing things. So thank you for your time this evening.
Jill, thank you. That was amazing. I always enjoy the opportunity to get the chance to either work together or just frankly listen to you talk about things, because it's always great. You bragged a lot on the PAC, so I'm gonna brag a little bit on you. The parent working group in general is fantastic. So much so that for a little while, while I was supporting their work directly with ICN, I would join their monthly calls and ask a bunch of questions about IBD that ended up helping my family and my brother. Second thing, Jill was part of the team at Mass General, and they put together a fantastic. It's a guide to starting a patient and family engagement team at the local care center, and you should check it out. I would try to navigate to it right now to get it in the chat box, but I don't know exactly where it lives. And so if you're interested in that, I'll put my email address in the chat. You can email me and we can send it to everybody. Jill, that's a fantastic resource. I send it to as many people as I can.
It was truly a labor of love, and I have to give shout outs, because in the typical ICN fashion, that the foundational document for that was already created by an ICN group. It was a collaborative group. And so we added our voice to that and took it to the next level. But I would invite other centers to take it to the next level. That's how we grow. That's how we learn. Thinking about things that Stanford's doing and San Francisco's doing, we're leveraging what they're doing locally and we're bringing it here to Boston. And so I think that's the power of the network, and just really getting inspired by what other people are doing is really something unique and special about our organization. So kudos to everybody for their contributions for that.
Mary Havens for the win. So I'm not going to go through all of my slides. You can see that Mary just put the chat in there. Also, you can feel free to email me about other things then. I really enjoy Star Wars. I'm happy to talk to any of you about it. This is Ahsoka Tano. She's my favorite character.
Oh, Baby Yoda.
Baby, yeah, my brother sent me one of those for Baby Yoda. If we had more time, I'd go up and grab it. By the way, we learned last week on The Mandalorian, his real name is Grogu. That's how big of a Star Wars fan I am.
I am there with you, man.
So a couple things I want to say. First, you can tell we have such a great community of folks that we have run 20 minutes over because we had so much wonderful content. The other thing I want to say is that other than the opening and closing, all of the content for tonight's session was developed and by a coalition of patients, families, and clinicians, and two, started at the local level, right? And so we very much believe that the best ideas start locally and are shared throughout the country. And they also come from working together with folks on different roles. I think as somebody who's worked in different healthcare organizations, I think that is our strength as ICN. And to do that, to continue that, we need all you to stay involved after tonight. So first, you can see our resources are available on ImproveCareNow.org. We've been putting them in the chat box. You can help us to meet our circle goal by signing up yourself, by finding 3 or 5 friends or connecting with your social network, making sure they get that bi-weekly email where new resources are shared and events like this are first shared. Or you can sign up to follow the Loop blog or join the PAC or parent working group. Connect with us on social media at ImproveCareNow.org. And I want to plug our survey one more time. Jill talked a lot about quality improvement and how they use it in the parent working group. We use it to improve nationally, to improve patient and family engagement nationally as well. And one of the ways that we do that is Sydney and Mary both with the survey. It's amazing. Is to take your feedback and adjust. And we want to do that for spring. Our next virtual community conference will be spring of this year. And if you sign up for Circle, you'll be one of the first to know the date and the content. So another reason to join. I think that's all I have. I want to say thank you to everybody at ImproveCareNow who helped put this on. Mary Havens, Sydney Bogartis, Mary Bauer, who's on tonight, who you all didn't hear from, our program manager, Kate Harrow, and everybody else with ICN. A lot of work goes into coordinating these, and I want to make sure those folks get recognized. Thanks for sticking with us for an extra 20 minutes, everybody. Appreciate your time. You're all wonderful. You'll be getting some follow-up emails about this with some of the information we shared. And have a great night.